Hey everyone, my name is Maddie Stewart, and I'm a first-year resident heading to Hopkins for radiology. I'm excited to be a part of the ACORE blog series, and I will be presenting based off the article Optimal Timing of Percutaneous Cholecystostomy Across Different Grades of Acute Cholecystitis, a retrospective cohort study. For more details, or if you're interested in the sources used for this presentation, please take a look at my full blog and all sources below. With that being said, let's begin. My presentation today is entitled Percutaneous Cholecystostomy and Acute Cholecystitis. Does timing matter? Special thanks to Sharif Ghazi for his help with this work. I will be walking through the study's design, a clinical tool the authors used to diagnose and stratify, and some possible applications from this interesting study's findings. Acute cholecystitis, or AC, is a common pathology in patients that are older and/or critically ill. In these populations, immediate surgical intervention may be too risky. In these cases, percutaneous cholecystostomy is a procedure that's used as a bridge to delayed surgery. But when should a cholecystostomy tube be placed? This study asked two important questions regarding this theme. Does earlier PC placement improve patient outcomes? And does the ideal timing depend on disease severity of AC? Regarding study design, this was a retrospective cohort study performed at a single center in Taiwan from October 2018 to December 2022. All included patients underwent PC for acute cholecystitis, and the researchers used the Tokyo Guidelines 2018 or TG18 to classify AC disease severity and to guide their analysis. So let's focus on the Tokyo Guidelines 2018 or TG18 so we can better understand this study. First of all, what is TG18? This is a clinical framework tool utilized internationally for evaluation and categorization of acute cholecystitis. Though its use is not standard practice in many U.S. hospitals, my home country, it can be lauded for its clarity and utility. A primary goal of the TG18 is to standardize the diagnosis and severity grading of acute cholecystitis. So let's discuss AC diagnosis using the TG18. TG18 diagnostic criteria for AC requires a structured approach. First, classic acute cholecystitis signs, symptoms, and findings are broken down into three categories. A. Local signs, like Murphy's sign and right upper quadrant pain. B. Systemic signs, like fever, leukocytosis, and elevated inflammatory markers. And C. Classic imaging findings on ultrasound, CT, HIDA, and MRI. Once the patient's symptoms are identified and placed into a category, they can receive a diagnosis using the TG18 diagnostic criteria for acute cholecystitis. They can receive a definitive or a suspected diagnosis. A definitive diagnosis requires at least one component from each category: local, systemic, and imaging. Or they can receive a suspected diagnosis of AC, which is requiring one component from List A and at least one from List B. Not only does TG18 structure diagnosis of AC, it also offers a framework to grade disease severity from 1 to 3. On this slide is a simplified summary of the severity grading approach. Please check out the official Tokyo Guidelines 2018 publication in my sources below for a more detailed approach. Grade 1 is mild acute cholecystitis with no organ dysfunction. Grade 2 is moderate acute cholecystitis marked by an elevated white count, a palpable mass, or prolonged symptoms. Grade 3 indicates severe disease with organ dysfunction, such as renal failure, hypotension, or coagulopathy. Now that we have a baseline for understanding TG18 diagnostic criteria and severity grading, let's get back to the study design. In total, there were 183 patients included. Patients were divided into groups based on disease severity. You can see here that the majority of patients had grade 2 acute cholecystitis. To address the questions of the study we discussed earlier, does PC timing impact outcomes, and does acute cholecystitis severity impact optimal timing? The patient groups were further subcategorized into PC timing groups. Did they receive their percutaneous cholecystostomy tube within 6 hours of admission, 6 to 12 hours from admission, 12 to 24 hours from admission, or more than 24 hours since their admission? For analysis, the authors focused on specific timing cutoffs that showed significant outcome differences. So when we take a look at the results, you'll see that for grade 2 acute cholecystitis patients, the key comparison is in patients who received percutaneous cholecystostomies before versus after 24 hours of hospital admission. For grade 3, you'll see the key comparison is receiving a percutaneous cholecystostomy before versus after 6 hours of hospital admission. So, the results of this study showed that, in terms of timing, an earlier PC significantly shortened hospital stays in patients with grade 2 and grade 3 cholecystitis. In grade 2, PC performed within 24 hours, reduced length of stay by 3 days. In grade 3, PC performed within 6 hours, cut length of stay about in half. However, timing did not impact in-hospital mortality, which was more influenced by patient age, comorbidities, and baseline severity. These findings suggest that PC timing can be triaged by severity of acute cholecystitis. So grade 3 AC can be approached with urgency, almost like a surgical emergency. Grade 2 still benefits from this early intervention, though less urgently when compared to grade 3. And in grade 1, early PC did not show a clear benefit, supporting continued conservative management for these patients. There are a couple limitations that we should note before moving on. First, it's a retrospective single-center study, so the results show associations, not causations. Secondarily, sicker patients may have received a percutaneous cholecystostomy tube earlier out of clinical necessity, leading to some type of selection bias. Additionally, the TG18 guidelines are not standard in the US practice, and not all hospitals have around-the-clock interventional radiology access to support such rapid percutaneous cholecystostomy placement. As I mentioned in the last slide, the TG18 is not routinely used in the US. Instead, clinical judgment, imaging, and local protocols help to guide decision making, but this study raises really important questions, such as, do we have systems in place to offer timely percutaneous cholecystostomy in the States, and could we replicate the findings from this study in a US multi-center context? In summary, earlier percutaneous cholecystostomy placement reduces hospital stays in moderate to severe acute cholecystitis. TG18 grading provides a structured way to triage urgency, and while it doesn't reduce mortality, early PC improves key care metrics like length of stay. This study highlights the vital role of interventional radiology in managing high-risk acute cholecystitis patients. And that concludes my presentation for this blog. Thank you so much for watching. I hope it gave you a clear and concise overview of my takeaways from the article, Optimal Timing of Percutaneous Cholecystostomy Across Different Grades of Acute Cholecystitis, a retrospective cohort study. For more information and more details, please see the blog below. Thank you.